The question is, what is the difference between seizure, SCI, seizure disorders and convulsive disorders? Now, convulsions means there is some motor activity. Seizures may not be motor. Seizure may not be motor. Let us consider something that someone is feeling some abnormal sensation in one limb. Suppose I am feeling some abnormal sensation in one limb, either painful sensation or some say tingling sensation or anything else. That is also one type of seizure. And convulsion means there is motor convulsion, a jerking of the muscles. There may be various types of jerking of the muscles. Sometimes jerking may be like this, straightening. Tonic type of convulsion. The straight, stiff. Jerking may be clonic in type, it is like this. Jerking may be tonic and clonic, like this. I have seen one child yesterday, just the child is just sometimes, the parents are complaining, the child is looking just like this. Within second, again normal. Within second, again normal. Sometimes the child is moving like this, heart chalte, stop. Then again moving. Now this is also one type of seizure disorders, and I have done immediately EEG. Within half an hour EEG done, and EEG shows there is an absent type of seizure. Suddenly the brain is not functioning. There was one teacher in our class, he was an MBBS student. During class, ma'am suddenly stopped writing. Then after a few seconds started writing again. When we asked her what was the problem, ma'am told that I am suffering from absent type of epilepsy. There is another type of seizure attack is that suppose the person is going. Suddenly there is loss of control and person is falling down. হঠাৎ করে পড়ে গেল দিতে। This is called atonic variety of seizure. Atonic variety of seizure. So lots of variety of seizure may be there. There may be another type of seizure where there is sudden jerking of the muscles, only one muscles, like this. This is called myoclonic variety of seizures. So seizure may be again, epilepsy may be again, say, or seizure disorder may be again focal seizure disorders, when a particular part, only one side, is under seizure, or it may be generalized, when there is whole body is involved. Okay, but that is determined when you get the history. If you get the history properly, then you can say that it's focal seizure. If you do not get the history properly, you cannot determine whether it's focal or generalized seizure. So either it may be focal, seizure may be focal or generalized, or maybe unknown also. Sometimes patient party cannot tell why this is maybe unknown also. Now why there is seizure? There is some excitation of the neuronal cells. There is some excitation of the neuronal cells. This excitation may be done after nerve cells excited হচ্ছে. Do you think the excitation may be spontaneous? নিজে নিজে excitation হয় অর্থাৎ সবার seizure হলো. There may be some provocational factors. Provocation. Or there may not be provocation. So seizure disorder may occur with provocation or without provocation. Suppose a child is suffering from high fever, and then the child is at a sudden rise of temperature, the child is going convulsion. And that is known as febrile convulsion. Fever is the provocative factor. Suppose a person is going, suddenly there is accident and there is trauma to the head. This is trauma is the provocative. Then the person is convulsion. Trauma is a provocative factor. Or the person is suffering from say meningitis, encephalitis, or tuberculosis or any other infection. Then it is also one provocative factors. Okay. So seizure may be provocative or non-provocative. So seizure there may be some provocative factors. কি ব্যাপার নেই হ্যাঁ এই ছাপার মতো এদিক ওদিক ঢুকছে কটা বাচ্চা এখন কি অবস্থা দেখো এরকম করে পাস করতে পারবি তো এতে কি হয় ফ্লোটা নষ্ট হয়ে যায় তাই না So seizure may be say there may be some provocative factors or there may not be provocative factors. Provocative factors may be of various types. Either it may be trauma, it may be fever, it may be some brain tumor issue, space occupying lesions, or maybe some infections. Okay. Or in some cases there may not be any provocative factors. That is called idiopathic type of seizures. So today our discussion will be confined to the seizure or epilepsy, mainly and provocative as well as non-provocative. Of the provocative type, we will see the most important is say febrile convulsion. We will discuss the febrile convulsion here because it is only in your topics. Then we will discuss the epilepsy in general, and I like also to discuss that there are some events which are not epileptic. They are mimicking epilepsy. That they are called paroxysmal disorder not due to epilepsy or non-epileptic events, NEE. There are a large number of non-epileptic events. They are mimicking epilepsy, but they are not actually epilepsy. Let us take some examples. Suppose a baby ages say 3 months or 4 months, during cry, suddenly becoming blue, and there is some convulsion. The baby is holding the breath. Baby is holding the breath, and then there is a uprolling of the eyeball and convulsion. This is called breath holding spell. It may be due to iron deficiency, or sometimes it may not be due to iron deficiency, or whatever it may be, this breath holding spell is non-epileptic events. I have seen several cases of say psychological in origin, some trauma, psychological trauma, or some child is suffering from, say adolescent is suffering from post-traumatic stress disorder, PTSD. Post-traumatic stress disorder, and he or she may mimic convulsion-like episode to draw the attention of the parents. This is called psychogenic epilepsy. So let us go to the topic itself after this brief introduction. Actually, we do not know the causes of the epilepsy in general, and we also do not know exact pathogenesis of epilepsy. Now, the 2 points may be there. The first point is that there must be some excitation of the neuronal cells. This is first point. If the excitation is repeated to the one part of the brain, then the manifestation will be focal in origin. If it is spaced throughout the brain, it will be generalized in origin. And there is also another concept is that when there is repeated excitation of the neural cells, then that brain is called epilepsy genetic brain or epileptogenesis. We are going to this definition as a febrile convulsion. Here you see the provoking factor is that provoking factor is fever, and it is not caused by any CNS disorder or any other things, trauma or other things or infections. So only cause is fever, and that is also giving rise to convulsion, and febrile seizure is not there. So febrile seizure means seizure without convulsion, without provocation. Febrile seizure, febrile convulsion means convulsion with some provocation. Now, this febrile convulsion may be simple febrile convulsion when the convulsion is very short duration, less than 15 minutes, not associated with any behavioral abnormality, not associated with any post-convulsive disorder. Simple febrile convulsion. It usually occurs only one time within first 24 hours of the fever. It usually does not recur. So if any fever more than 15 seconds, recurring after the first 24 hours, or doing some abnormal behavior, that is called complex febrile seizures. We see lots of cases of febrile convulsion, large number of cases. These are most common thing, lots of cases. Okay, so in that cases, we simply tell the parents that give the antipyretic for fever. Remember, it is not related to the, if you reduce the fever, convulsion will disappear, that is not the fact. It is not related to the degree of fever. This is number one. But for consolation of the parents, antipyretics should be given in these cases. And if the convulsion is repetitive, then usually we give one benzodiazepine group of drug, lobazam group of drug, for 2 days to prevent the onset of convulsion. Okay. So this is the this is the site visible. Visible. Two problem much colored. So remember it is incidence of prevalence of febrile convulsion is higher, 5% of cases, and risk of epilepsy higher risk in patients or children whose parents or whose siblings, elder brother or sister, they are also suffering from febrile convulsion. And the risk of recurrence and epilepsy. But we do not bother about the epilepsy because febrile convulsion usually occurs from 6 months to 5 years and usually disappears after the age of 10 years or 12 years. Now, there are some changes is that febrile convulsion may occur in neonate also, and it may occur at the age of 12 years or 14 years also. But the most common age till now is 6 months to 5 years of age. This is the type of convulsion. Usually febrile convulsion is generalized tonic and clonic, which I have discussed. Tonic and clonic is like this type of convulsion. And so if you treat that, if there is convulsion, if you treat the convulsion by giving the benzodiazepine group of drugs. So in a case of febrile convulsion, what we should do? What is the mechanism of febrile convulsion? Actually, mechanism is still not known. Probably there is a polygenic incidence. Polygenetic incidence means large number of genes are involved for febrile convulsion. And we should exclude any CNS involvement in febrile convulsion. Any CNS, nervous system involvement in febrile convulsion. That is the reason why if febrile convulsion occurs less than 6 months of age, we usually advise to do the lumbar puncture. Lumbar puncture. Okay. to study the CSF. One of my MD student, now associate professor, Murshidabad Medical College, she has done thesis under me, and the thesis was topic of the thesis was the incidence of meningitis in febrile convulsion from 6 months to 18 months of age. And she has got 2 cases of meningitis where there was no feature, there are no clinical pictures of meningitis, but they presented only with the febrile convulsion. So the lesson is that if the child is aged less than 6 months of age, you should do the lumbar puncture to study the CSF and exclude meningitis or in the CSF. This is the management. Management is not tough enough. It is very easy to do the management. Nowadays, the midazolam is available. Midazolam is available, and per spray of the midazolam, there are 2 strengths, 0.5 and 1.25. And you give the midazolam nasal spray in both nostrils, nasal spray. There is also Bakkan midazolam is available. Give the spray, and immediately the seizure will be controlled. Just hold the baby in hand and give the nasal spray. One of my baby at the OPD came. The baby was suffering from Dravet syndrome. It is severe type of febrile convulsion, Dravet syndrome. And we immediately control the seizure by giving the midazolam infusion in the both nostrils. Or if it is not available, you can do the parectal diazepam also, 0.5 mg per kg parectal diazepam also. And if you are very expert and everything available in medical college, you can give lorazepam 0.1 mg per kg. So these are the various processes of treating the convulsion. I am not treating about drug doses. You may not remember because it is available everywhere. But principle you should take care of. If the convulsion persists, sometimes febrile convulsion may persist. You are trying to control the febrile convulsion, but convulsion may persist, not relieved by your first line of treatment. Then what will happen? If the convulsion is persist more than 30 minutes, it's called status epilepticus. But nowadays we are not thinking about 30 minutes. A child presenting with the so if the seizure persists more than, say, if child is presenting with the convulsion, we should consider his status epilepticus. Remember for the future, suppose you are intern, you will be intern after a very short time, and you will be given whole load of the management of the emergency. You will have to do, because on-call doctor will come late. So if there is any convulsion, child presenting with the convulsion, child is presenting with the convulsion, you should consider it as status epilepticus and manage as such. Or if a child presenting is a more than 5 minutes with convulsion, it is status epilepticus. Or if the convulsion is persisting more than 5 minutes, you should consider a status epilepticus unless ruled otherwise. But official definition is that convulsion more than 30 minutes should be defined as status epilepticus. So if you are asked what is status epilepticus, you should say the convulsion persisting more than 30 minutes. But there are 2 exceptions. Usually when a convulsion persists more than 5 minutes, it is considered as status, because it will persist up to 30 minutes if it is not treated. This is number 1. Number 2, a child presenting with the convulsion, we should not count the time. We should consider the status. In a case of status epilepticus, we should manage first with the, say, first line of drug like benzodiazepam. Then we go to the second line of drug like peritone and other things. We will discuss these things again. Let us go to the next slide. I have already discussed this. Remember, the MRI, EEG, they are not necessary in simple febrile convulsion. Only in case of complex febrile convulsion, or there is repeated febrile convulsion, or there is some abnormal behavior in febrile convulsion, or is more than 15 minutes convulsion persisting. In that case, we have to exclude any CNS involvement by doing MRI or EEG to find out the lesions. And EEG should not be done immediately, it should be done after 2 weeks of the, at least 1 week after the onset of febrile convulsion. so that the abnormal discharge subsided, and then WD to see the actual figures. These are all discussed figures. Prognosis is not bad. EMR is the febrile convulsion persisting for a long time. It can give rise to medial temporal sclerosis. It means temporal lobe, medial side, lower part may be sclerosed, and that can give rise to the persisting long time convulsive disorders. So it should not be persist more than 30 minutes. If the febrile convulsion is going to status epilepticus, it can give rise to medial temporal sclerosis. Medial side of the temporal lobe may be sclerosed or fibrosed. That can give rise to permanent disorders of epilepsy. This is the epilepsy. It means the abnormal neuronal activity or discharge. Remember, only one convulsive disorders which is unprovoked. That is not the epilepsy. Single seizure or single convulsion, that should not be diagnosed as epilepsy. But repeated convulsion, at least two, that should be diagnosed as epilepsy. Or if there is single convulsion and after investigation you are finding some abnormality in EEG or MRI, you may think of there is the chances of epilepsy further, you should define as epilepsy. So what is the definition of the epilepsy? There is no provocative factor. At least two convulsions should be there. This is second point. Or if there is one unprovoked seizure or convulsion, but investigation reveals there are chances of convulsion further, that's it. That should be defined as epilepsy. So this is the features of epilepsy. This is all I have already discussed this. Focal or generalized epilepsy. This generalized epilepsy may be say focal, generalized or unknown onset, and there will be non-motor type of. I have discussed the sensory type of epilepsy. Some abnormal sensation may be there. If it is originated from one type, one place, it is focal, spreading throughout the brain, it is generalized. It may spread to the corpus callosum, or it may go down up to the pons and then changes, exchanges, and then go upwards also. Two pathways are there. It should not be discussed here about the different pathways of epilepsy. Okay, but remember the one side of the brain is excited, then it spreads to the other sides of the brain also. That is generalized. It may be focal, it may be controlled within themselves, focal. This focal convulsion may be only with the motor manifestation. Then we will call it as focal motor. Focal manifestation may be sensory origin, so focal sensory. Or focal manifestation may be with some abnormal behavior, that is called complex focal. But this terminology nowadays have changed. So terminology now is that focal convulsion without any abnormality or complex behavior, a focal convulsion with some complex behavior. This is the recent terminology. Next, this focal convulsion starting with the one place, then it may proceed to other areas. That is called Jacksonian march. Jacksonian march. It is starting with the thumb or get to, then paging downward throughout the body. The focal convulsion may be say mild focal itself, may be focal complex, focal generalized. Okay. Generalized convulsion may be different types. Tonic convulsion, clonic convulsion, tonic and clonic, myoclonic, atonic and absent. So these are the different types of convulsion we have told you. So these are the different provocative factors may be there. We have discussed this. Now unprovoked convulsion means idiopathic convulsion. Provocative factors should be determined. Every cases of convulsive disorders, we should find out any provocative factors. Whether there is any say infection or any disorders, say facial lesions or any trauma or any say hemorrhages inside the brain or any vascular abnormalities or any other lesions. It may be some thrombus manifestation, it may be old infarction. Sometimes in newborn we have seen some baby may suffer from hypoxic ischemic encephalopathy. It means newborn is not crying after birth. If the newborn is not crying after birth, there may be some changes in the brain that is called hypoxic, oxygen pump, ischemic, less blood supply, encephalopathy, meaning damage of the brain. That can give rise to some focus in the brain. And that focus may be due to some infarction. That is called gliosis. A part of the brain is damaged. And that gliosis may in future, so after 1 year or 2 years, may present with a convulsion. Or sometimes in case of turn baby, we see one other things, a portion of the brain at the different area may be damaged. And that can give us to encephalomalacia. Encephalomalacia, large part of the brain is damaged. That can present with the convulsion. So all these secondary factors you should say find out, and if you do not get anything of the cause of the convulsion, then you can come this is a case of idiopathic variety of epilepsy. Okay? So in a case of convulsion, you will have to search for this. We have seen a cases of repeated convulsion with some say intelligent quotient diminished with some autism-like manifestations. I published this paper in British Journal Medicine. If you search this, you will get this very good article. The convulsive disorders in tuberous sclerosis. One of my intern. The name of the intern is also there. Now he is professor. So the tuberous sclerosis and autism with convulsive disorders. That case is presented in 2008 in BMC Pediatrics journal in the outside. That is there is 1,000 times citation is there, 1,000 times. Now, everybody quoted this. This reference was very good presentation. So, you see some tuberous sclerosis lesions, some abnormality, maybe there can give rise to convulsion. Sometimes some say enzyme disorders, 3-beta hydroxysteroid dehydrogenase deficiency can give rise to convulsive disorders. Or some structural abnormality in the brain, say cerebellar structural abnormality, Dandy-Walker syndrome, or the posterior fossa abnormality, cerebellar vermis is not properly formed. That can give rise to convulsive disorders. Or sometimes a periventricular hemorrhage in preterm baby, that is called periventricular leukomalacia. That can give rise to convulsive disorders. So whatever thing you can remember which can damage the brain can give rise to convulsion. So these are called factors during convulsion or etiology of the convulsions. Or sometimes there may be some genetic disorders which may attract some channels, say sodium channel functioning disorders, potassium channel functioning disorders, some synaptic membrane functioning disorders. I am giving you one example, sodium channel functioning disorders. SCN means sodium channel, KCN means potassium channel. So, sodium channel functional disorders, one example is Dravet syndrome. Severe convulsion. After fever, there is severe convulsion. Very difficult to control. Okay. So, these are the various factors which can give rise to this. I think it should not be discussed this. Sometimes the convulsion may be say autoimmune encephalitis. Antibody is formed against the own tissue. And usually the extrapyramidal system is first involved in this case. in autoimmune syndrome. And you will see some abnormal movement in the lips and tongue. During daily round, the child was admitted in other unit. During daily round, we have found one cases of these autoimmune disorders. The baby is constantly putting the tongue outside. Movement to the tongue. We immediately thought it may be some basal ganglia disorder may be there, and we searched for that, and ultimately we got that it is an antibody produced against the NMDA receptors. NMDA receptors. That is called autoimmune encephalitis. We treat with the methylprednisolone and child is improved dramatically. So autoimmune encephalitis is very common nowadays. It may be a precipitating factors following some collagen vascular diseases also. So that can give rise to that. So we are not going in details. That we discussed. Gene testing or whole exome sequencing is now a very, very upcoming investigations nowadays, gene testing. And we are also doing gene testing in some patients of behavioral abnormality now. Now, Anupam is one of my friend, is now head of the department of zoology, Burdhan University, is a very important expert of genetics, and he is doing whole exome gene sequence of my patients. We are getting lots of abnormality in the gene, which is giving rise to various types of abnormalities in the behavior of the children. We have published 462 cases in journal recently, in 2025. Go to the next. I have discussed these, everything you know from the previous discussion. These are the simple side dash. Now, when there is thinking in structural abnormality, we should do MRI investigations to find out what is there. Now, this is one thing, is a pyridoxine dependent cause. Huh?
Vertical dysplasia,
medial part, medial temporal sclerosis. তোমাকে একটু আগে বলে দিলাম, medial মানে medial temporal sclerosis. Now, there is one type of convulsion, that is vitamin dependent convulsion, the pyridoxine dependent convulsion, not uncommon nowadays. Particularly in neonates, convulsion is going on, and if you put 100 mg of pyridoxine, convulsion suddenly stopped. That is called pyridoxine dependent convulsive disorders, and lifelong pyridoxine vitamin should be given to the child for prevention of convulsion disorders. ঘুমুচ্ছে নাকি রে তোর পাশে ঘুমিয়ে গেল, তুলে দে একটু, ঘুমুচ্ছ? What is pyridoxine dependent convulsion? Pyridoxine dependent convulsion. যাই হোক, what it may be, these are the disorders which may be found. Group 1 means glucose transport disorders, and the glucose is not entering inside the cells. If the glucose is not going to the brain cells, or the brain is dependent on the glucose, then what will happen? Brain cell will be excited, there may be damage of the brain cells, that can give rise to convulsions. So these are the various causes of convulsion. We should not go in details of this. Now, this is important things. One type of convulsion that is called benign neuronic epilepsy. Centrotemporal spike. And as it is not related to the EEG. EEG is usually in radiology classes. So spike means some sharp wave like this. We will get this type 5. Usually we get in the normal human being, you will get some beta spike, or this a small amount of spike like this, beta spike, and it will present at this moment, because you are giving some focusing or listening something, so your brain is excited this time, so there will be beta spike, very small wave spike. And when you are closing your eye and taking rest like that student who was sitting there, during that time you will get the alpha wave, so slow wave. Brain is not accepting anything. And during the sleep, you will get another thing that is called delta wave, long time delta. And there is another wave that's called theta wave. Theta delta is usually found in children and during sleep, deep sleep. But alpha beta is very common. So these are the things you should think of. And in case of say EA, you do the EEG, very important investigation, you get this. Here are some symptoms. I think you may not remember this. You will get these cases in the OPD. And if the question is very tough, sometimes you may be given waist syndrome, infantile spasm, because it is common. Particularly this baby who is suffering from say birth asphyxia or some brain damage, you will get this type of common. What is happening? The baby at the age of 6 months, mother will complain that my baby, while sitting, just suddenly doing these things. Particularly after awakening from the bed, the child is frequently either flexing or extending the head. So it may be flexion type or extensive type of movements of the head with some stiffening of the hands and other things. That is called waist syndrome. And there is very abnormal EEG is there. It may be two types. There may be some cause where there is birth asphyxia is present, or there may be some no cause where there is no cause, there is a cryptogenic waist syndrome where you will not get the cause. There are the different types of say syndrome, Lennox-Gastaut syndrome, or say progressive myoclonic epilepsy due to progressive degeneration. Now, this part is important, clinical evaluation. The most important thing is the history, and if it is possible, ask the parents to record the convulsion, video recording of the convulsion. Nowadays, we usually ask the parents to record the video of the convulsion, and from that video, we can diagnose whether the convulsion is real or it is some mimicking the convulsion, non-epileptic events or not. Okay, so this is a very important thing. How the convulsion started. So video recording, phone is available almost everywhere, right? And you can record the. Let us think these things. That so the history is very important. Anything which is for neurocutaneous markers, this is important. You should examine the skin also. Suppose you are getting skin the neurofibromatosis. That is called neurofibromatosis. Neurofibromatosis, you will get some neurofibrom also present in the tumor in the brain that can give rise to convulsion. Or suppose you are getting some say adenoma sebaceum on the nose and other area. What's that? Adenoma sebaceum. That is called tuberous sclerosis. You can get it. Or you can get the other things of neurocutaneous disorders which can give rise to convulsion. So skin should be examined properly. All things. Remember, you should do EEG. I am not discussing the EEG here, but normal EEG does not exclude epilepsy. Or only EEG present but clinically normal, that is also not epilepsy. So your clinics is very important. Clinically, the child is suffering from epilepsy. EEG is normal, you should treat the child for epilepsy. But clinically, the child is normal. EEG showing the abnormality, that may not be epilepsy. So your clinics is very important. Now, in case of say MRI of the brain, you should give some say unprovoked seizures where you don't know. Suppose there is no fever, febrile convulsion in a child. You will have to do MRI and EEG. That's it. In case of provoked, the fever, you know the cause. But in case of provoked, like say head trauma, accident, in that case you will have to do CT scan to find out what is the nature of the blood accumulated or not. You will have to examine the other metabolic causes, whether the hypoglycemia present, hypocalcemia may be present, hypomagnesemia may be present or not. Remember, this type of metabolic electrolyte imbalances or say metabolic other abnormalities are very common in neonate with seizure. In the newborn with seizure in the day 1 seizure most common is hypoxic ischemic encephalopathy or birth asphyxia. Day 2 seizure is most common due to some metabolic abnormalities, hypocalcemia, etc. Day 3 and 4 onwards, there may be metabolic abnormalities associated with infection, meningitis, others. These are very common questions asked in the newborn. What are the causes of convulsion on day 2? You will have to say these are metabolic abnormality along with the HIE. What are the causes of convulsion after day 3 or day 4? All these causes of convulsion like HIE or say metabolic disorders and septicemia meningitis will come in considerations. Okay. And if any baby, newborn baby suffering from septicemia, 33% cases they are suffering from meningitis also. So in a baby who is suffering from septicemia, 33%, 1/3 of the cases suffering from meningitis, we will have to do the lumbar punctures. So what a drug should be given, and remember the drug is given depending on the therapy, monotherapy, single drug. Now it is the fashion of the neurologist to give multiple drugs in management of seizure. It should not be done. You should give one drug, increase the doses of the drugs to the highest level. If it is not controlled, then go to the other drugs or second drug. Either reduce the first drug or keep the first drug along with the second drug. Gradual tapering. Don't go just 2 or 3 drugs simultaneously. But these are the different type of drugs and their mechanisms also. We are not discussing this. You know from the pharmacology book, pharmacology study. These are the sodium channel blockers, gamma-myopin, carbamazepine, phenytoin, GABAergic, gamma-aminobutyric acid, that is inhibitory neuron. That is like this. And SV2A binders, Levy-tire system. Very important drug nowadays. What it is done, it blocks the synaptic vesicle glycoprotein. SV2A is the glycoprotein present on the synaptic vesicles, and that can be blocked by the Levy-tire system. Very good drug for focal and generalized convulsion. Nowadays, this is becoming a very important drug for management of the convulsive disorders as a second line of drug after the mirazole and other things. We are going to that. Side effects you should keep up. The valproate should not be less than 2 years of age. It can give rise to liver damage. It can give rise to alopecia. And in female, you should not give valproate because it can give rise to teratogenic effect. Previously, sodium valproate was very good drug, but now there are tremendous side effects are coming. Usually, I've heard this valproate in less than 2 years of age and in females, but it is also a good drug for other cases, sodium valproate. Now, Levy-tire system side effect is now recorded result can give rise to behavioral alteration, and instead of that, there is another drug which is coming, the baby-tire system. Levy out of baby. Baby-tire system is more active than Levy-tire system, but cost is much more. Now, Stevens-Johnson syndrome. You know about the Stevens-Johnson syndrome. That is, so that can give rise to, it's a very important drug is carbamazepine can give rise to this. Now, prolonged seizure, so we have discussed more than 5 minutes we should take a prolonged seizure. We should immediately control this with that drugs which I have discussed before. These drugs are discussed before, lorazepam, midazolam or rectal diazepam. When to start treatment? Definitely within 5 minutes, immediate. And if you give time up to 30 minutes, if the more than 30 minutes, every chance of damage of the brain. I have discussed this. Mesial temporal sclerosis, or other areas may be damaged. Now, if the convulsion persists after the initial therapy of benzodiazepine, what is the next drug? Next drug is the phenytoin sodium. Okay. Remember the phenytoin sodium, or it may be valproate or Levy-tire system. So this is the If the second line duct, first line duct is that duct, second line duct is this. Now, third, consider phenobarbital in infant. In infant, usually we give the phenobarbital. There are a large number of causes why you should give the phenobarbital in infant. First is that it reduces the free radicals in the brain. Number one, it maintains the germinal epithelium integrity of the ventricle. Preterm ventricle, germinal epithelium integrity. It gives rise to sedation, which is desired in case of baby, newborn baby. That's why in newborn we prefer phenobarbital. Or infant we prefer phenobarbital. But we should not give phenobarbital in older children because it gives rise to some assessment difficulty. It can give rise to sedation. Number one. Number two, it can give rise to hyperreactivity. Number three, it can reduces the intelligence quotient. Mental subnormality may be increased in phenobarbital therapy. So that's why above the infant age, we should not give phenobarbital. Now remember, what is refractory epilepsy? Refractory epilepsy means when the two drugs fail, benzodiazepine and non-benzodiazepine agent. Benzodiazepine and this is the second line drug. When these drugs also fail, then it's called refractory epilepsy. And what is super-refractory? When it is persist more than 24 hours, convulsion persist. These are the important cause of the, say, non-refractory type or non-refractory, super-refractory type epilepsy. So we are not going into this. Now, what do you think of this in case of refractory or super-refractory? You will have to investigate whether there is any abnormality or secondary factors present or not, any metabolic factors or anything present or not. Okay? And you will have to exclude that. Now, remember the case of, say, refractory epilepsy, what we do? We usually give some, say, I think it will be status epilepticus. We usually give some midazolam infusion or thiopental infusion to produce the coma stage in case of refractory stage. So in a refractory epilepsy, we induce coma by midazolam infusion or thiopental infusion or ketamine infusion so that the epilepsy is controlled. If it is not controlled with that for 24 hours, it's called super-refractory. In super-refractory cases, we should go for surgery, either the vagal nerve surgery or deep brain surgery to thalamus or hemispherectomy. Sometimes one part of the brain is removed. So, epileptic surgery should go. And before that, we should find out whether there is other causes present or not. And investigation like the spectroscopy or say positron emission tomography, single photon emission computerized tomography, these are various investigations to find out the cause. There may be sudden infant death syndrome in case of epilepsy also. Sudden infant death syndrome. There is death of the child for epilepsy. So everyone must be cautious. Doctors, parents should be cautious about this. Status epilepticus, more than 30 minutes we discussed before, and with seizure presentation or more than 5 minutes present. Okay? Status epilepticus. Now this is the how we manage this. Now airway, breathing, circulation, ABC. This is important thing. Then you should do the convulsion control. Convulsion control by benzodiazepine. And then after convulsion control, you start drip, you take the blood for investigation and start drip. So first thing you should do first see airway, breathing and circulation. Breathing is going on, control convulsion and then start IV drip and take the blood for investigations. What are the drugs? Just like before I have discussed this, lorazepam, midazolam, diazepam. These are the initial drugs. And if CFR is more than 5 minutes, then give second group of drug, second dose of the drug. If it still fails after second dose, then go to the third dose. Phenytoin or phosphophenytoin. Phosphophenytoin metabolized to phenytoin. Remember, phenytoin should be given in normal saline. You should not give phenytoin in dextrose because it will get precipitated. And then levetiracetam, valproate, and lastly phenobarbital. These are the second line drug. If till it is there, then you shift the patient to the ICU and start the drug which are giving rise to induce the sedation of coma like this. Midazolam infusion, pentobarbital coma, which just discussed. After this is a thiopentol induced coma, etc. Ketamine infusion. Investigation, we already discussed, you should do all these things. EEG monitoring should be continued properly, supportive, you take high. Non-epileptic events means where there is no true epilepsy, but there are epilepsy-like manifestations. I am going rapidly like this. This is the syncope, vasovagal attack. Person is in very claustrophobic condition, feeling very much troublesome in large gathering. There will be sudden fall, syncope will be there. Okay, there will be cardiac arrhythmia, giving rise to syncope, or movement tics disorders, which is not epilepsy, that can give rise to sleep. Parasomnia, sleep disturbances. During sleep, there is sudden rise and sudden movement. They are called somnambulism. During sleep, sleepwalking, or night terror, virat, bhoy peye gel. Night terror. These are the various things. And migraine variant, and lastly, breath holding spell. Psychogenic epilepsy, or mimicking epilepsy, but actually not true epilepsy. These are all epileptic mimicking conditions. I think we should end here because the time is up. Time is up full. And there is no need of discussion this further. This will not come in the exam. Only you should know this. So from today's discussion, what we have learned? We have learned what is the definition of epilepsy, 2 or more than 2 unprovoked seizures, what is the different definition of febrile convulsion, fever with convulsion, convulsion following fever. Next, what are the different types of febrile convulsion, simple, complex or atypical febrile convulsion. Then how to manage the febrile convulsion. Next, epilepsy, what are the different types of epilepsy, partial and general, what are the different types of partial epilepsy, focal epilepsy, focal motor, focal sensory or focal complex. And generalized, we have discussed before. How to manage the case, diagnose cases of epilepsy, how to manage it, and what is status of epilepticus and step-by-step management. Okay.